Okay. Well, welcome. Thank you for coming to a talk that I've done a number of times and that I really enjoy doing. I should introduce myself. My name's Chris Thompson. I'm a senior staff specialist at Royal Prince Alfred Hospital, where I've worked most of my life. And I've had a long-standing interest in breathing and ventilation, and perhaps since the advent of newer anaesthetic machines, I've really been able to learn a great deal about how to apply them. Now, I'd like to start off with a disclaimer. This talk was supported by Dräger in that they paid my airfare down here and put me in the hotel tonight, which is very kind of them. I've always been reluctant as a clinician to do talks in that way, but I appreciate their help. The other thing is that I've actually worked with Dräger as a technical advisor for almost 15 years, going back on a number of machines, and with other manufacturers. I have an inherent bias towards their products simply because I understand them very well and I think they're quite good. If that comes out, I'd like you to factor in the fact that I do work for them. Having said that, the talk is my own talk. They've had no role in the content of it, and I hope it's useful. I try to make it as clinical as possible, and I'm not really talking about the machine. Okay, so I guess I'd like everyone here to reflect for a moment on what it makes us great as anaesthetists. We are all renowned for our ability to put cannulas in and to give drugs in a very sensible and controlled fashion to get people nicely off to sleep. One of the other skills that traditionally has been almost our private domain in the hospital is bag mask ventilation, the ability to get a good seal and stay out of trouble. And when things go badly wrong in a can't intubate, can't ventilate situation, that's our problem. It sheets home to us. So I want us to reflect a little bit on whether our mask skills and our ability to ventilate patients are really as good as they could be, because there are a number of factors that I think have tended to de-skill us. And in the back of your mind, I just wonder how happy you'd be to look after some really kind of sick patients. I've done pretty much most of these, and they all carry unique challenges that we have to deal with on a regular basis. The question is whether we feel in ourselves we could do a job that's as good as any intensive care doctor in looking after their lungs. And as you know, sometimes the intensivists are nervous when they go to theatre because they think they'll come back worse. Well, I can confidently tell you we've got tools now that let us send them back better. And the only thing that limits us is our knowledge of how to use these tools. The modern anaesthesia machine is vastly better than what we've ever had. And at the same time, because so many of our patients are healthy and well, we've de-skilled in our mask ventilation and bagging skills. We give people high inspired oxygen so that even if we ventilate them poorly, everything looks great. And when it comes to get a bit tough, we can put a laryngeal mask in often and secure an airway that way. But without undue emphasis, the failure in can't intubate, can't ventilate is normally a failure of the ventilation part. And the reason why all of us are sitting here with saturations well above 95 most likely is because we breathe. It's not because we control oxygen. We don't. We control CO2, we control breathing. A and B and ABC of a resuscitation is about airway and breathing. If we breathe properly for our patients, they'd be fine. Now imagine that every patient you took to recovery had to have an aramine infusion because we wrecked their heart so badly that we had to do that for all of our patients, or that every patient shivered and needed a warmer, or that every patient had to have a bit more fluid pumped in. We would personally perceive that as being some kind of a deficiency on our part, that we couldn't restore the patient to their normal physiology. And yet from the respiratory point of view, we fail completely regularly, and almost every patient is given oxygen in recovery to deal with the failure to return their breathing to normal. And I kind of would like to make a picture of what I think is an ordinary respiratory care in the anaesthesia environment. We typically give very high inspired oxygens which conceal a myriad of sins and are themselves contributing factors to collapse and to a worse outcome. Less commonly, we use 700 by 10 these days, but it's still very common to use large tidal volume modes of ventilation. If we use PEEP, we just put it on 5. We don't really individualize it. A few people would know how to titrate PEEP. We use an A ratio that's, I think, archaic and unhelpful. If there's a problem, we just turn up the oxygen, you know, and we can get around it generally just by doing that. We don't really work hard on fixing the root cause of that. A lot of people have a tendency to pre-oxygenate with a relatively poor mask seal, not achieving necessarily what they want, but giving the drugs until the patient becomes apneic, supine, and then attempts to establish ventilation after apnea when the tongue has flopped back like a ball valve against the opening of the pharyngeal inlet and so on. We paralyze a lot of people. So this is sort of the old style thing. And like post-operative pain, if we're to do any better, there's no one magic bullet. There's a whole lot of things we have to do. And I guess I came to the point where I thought, well, if we apply the multimodal model to ventilation, then could we do better? It's been shown in ICU, and the question is, what about anaesthesia? Now, a lot of people think that lung collapse and problems like that don't happen in children. There's this fantastic paper by Thompson. You can see there a picture on the left of it's the same patient, an MRI, and they just got normal children, gassed them down, and they were having CTs of their head, and to their surprise, the lungs collapsed. So they did a study of putting 5 of PEEP on. So these were gaseous inductions with a T-piece. They added a 5 centimetre PEEP valve. And you can see that ZEEP versus CPAP made no difference. And this was normal. All the patients collapsed in a standard gaseous induction, healthy children. But if they did a recruitment manoeuvre and then dropped them back to 5, the lungs were great. Practically every single one of them. So you have to recruit people. And then there's a whole lot of things. I'll have a big picture of all the little things you could do. But Konstantin has done the only really good outcome study, and it's an unbelievable result. You see, he wanted to find out what happened if you did a little bit of a variation on normal ventilation. Would it matter? In other words, would we try a bit of an ICU-style ventilation technique? Now, as you know, when I trained, the intensive care faculty was part of our faculty, you know, and I did a lot of time in ICU. Nowadays, an anaesthesia person does very little, but the ICU people see the people we stuff up, and they come a couple of days later. And Foutier got sick of it, so he wanted to try to find this out. In fact, what he did was benign. He only reduced tidal volume and gave a reasonable amount of PEEP and did recruitments. That's all. And this was the difference in a very large multi-centre study. There were some obvious changes in ventilation situation, you know, less ARDS, but the wound infection rate went down, the stays in ICU went down, the need for ventilation went down, and there were marked difference in overall outcome and cost. And that's, I think, really fascinating. And one of the problems is if you look after a very sick patient and collapse their lung and get any soiling, particularly, you know, infective soiling from saliva around rotten teeth, and put that stuff directly above a collapsed bit of lung, what's going to happen, you know? Anyway, so the sort of things that ventilation does when we finally get around to putting them on the ventilator is it doesn't distribute oxygenation well. And if you get a sick patient and you try to ventilate non-collapsed lung, you've got to ventilate it much harder because there's not much of it to get the CO2 out. And if you get secretions, you'll get bronchitis or pneumonia. If you run out of a patient without good muscle tone at the end, obviously that's bad. And chronic ventilation knocks off your muscles, so that's no good. In the end, you want to avoid getting people onto ventilators and having adverse outcomes. So what are the sorts of things we can do? Well, planning ahead's really vital, especially people with beards and things. I don't use pre-oxygenation at high levels of oxygen. I'm not a great believer it makes much difference. When you really need it in a fat person, Do you really think it gives you enough time to save that can't intubate, can't ventilate scenario? No. What saves you is sitting them up a little bit maybe when you start and being able to ventilate them well and having a really well thought out plan of who you're not going to try a conventional induction on, who you're going to do something different. And pressure support. Now, if you're in ICU these days and you're in extremis, they don't generally lie you down and then sedate you and pre-oxygenate you. They keep you sitting up when they intubate you. And they'll induce non-invasive ventilation through a mask. That's what I do now on every induction of every patient until I'm good at it. Because we have machines now that we can use pressure support type modes to induce a patient, make sure their ventilation's really good, get the oxygen in, and achieve much less of a problem with obstruction on induction. Generally, I think there's a movement to avoiding paralysis. That little box has changed in the conversion, but generally smaller tidal volumes going a bit faster are much more effective. PEEP should be optimised. The IE ratio should be 1:1 for every ventilated patient. A long technical discussion, but if you do it, you'll get lower airway pressures, better distribution of ventilation, and if you do gases, and you can go do the test, we'll show you a bit later. Lower inspired oxygens, recruitment. If you've got a problem with oxygenation, there are only two causes. One is global hypoventilation, like in recovery, where the opioids have got the better of the patient. Their minute volume is down. That makes people blue. Or regional hypoventilation, low VQ ratio parts of the lung. They cause hypoxemia. If you have 50% reduction in your VQ ratio, only 30% oxygen completely fixes that. So if you're running 40% or 50% inspired oxygen and your patient has a low saturation, something is really wrong with their ventilation in some part of their lung. And you should fix that, not just turn the oxygen up. And I'll show you how. Okay, and then the rest is sort of fairly obvious, the sort of stuff that you need to do. Fairly obvious modern sort of anaesthesia techniques. So we're going to focus on what we can do in the lungs. But there's one more little thing, that last one that popped up. Don't blow off all their CO2. If you blow off CO2, the body has a big reserve. We have 16 litres of CO2. If you run me on end-tidal CO2 of 30 for a couple of hours, of that 16 litres, a quarter of it will be gone. 4 litres, okay, because my CO2's dropped down by a quarter. It will take me 20 minutes of apnea to get that CO2 back, okay? So if you're going to blow off CO2, your patient will have global hypoventilation and need oxygen post-operatively. Okay, so now let's look at the thing that's made it all different, is that we've got machines now that we can recruit with, we can use pressure support on induction, and often people don't understand what's different about them inside. And this is true for a Dräger machine, so this is not true for a GE machine or a Mindray machine. They've done something which I think is very clever. So here's a picture of an ICU circuit. On the left, there's a way to push gas in when you need to, and on the right, there's a PEEP valve. So I haven't got a laser pointer, but basically when you breathe in, they drive gas in and close the PEEP valve a bit. Air comes into the patient. When you want to exhale, they release the PEEP valve to your PEEP value and stop pushing it in, and you exhale. There's not much dead space in that circuit. There's not a lot of pressurizable volume. There's no efficiency because all your gas goes out. So this is the machine that you're familiar with. It's still got the little patient circuit, goes round and round at the back. There's a big bottle of soda lime in the way. To breathe in, you've got to breathe through the soda lime. You've got to get it through a bag and extra tubing. So there's a bit more resistance. And when you breathe out, you can't breathe out once the bag is full until you crack the APL valve. And if anyone there thinks they're doing a favour to a patient by putting an APL valve on 5, they're not. It makes it harder. And then a GE circuit or any modern type bag and bottle ventilator is really just a rearrangement of the deck chairs of the old style machine. But what Dräger have done is, I just remind you of the ICU circuit, they've left the ICU circuit where it was. So that little bit on the left that says blower piston, this one has a blower, is the delivery of gas device. And the PEEP valve on the other side is an ICU PEEP valve. So on inspiration, only that bit in the bottom half is working. The bit on the bottom half is doing exactly what that is. So you've got an ICU ventilator in your operating room with a reserve of gas at the back. And that's what means we can now do things we could never do. And there's one other small detail, and that is that there's a very high resolution screen with lots of very accurate waveforms. And most important being flow. On our old machines, we had CO2. The CO2 is not very important, really. It's a secondary consequence of adequate ventilation. But it was the only thing we could measure for 20 or 30 years. Now we've got really high quality flow curves, and they're built into the machine. As soon as you see exhaled flow, you know the CO2 is going to be okay. You know gas is coming out. Anyway, so I'll focus on looking at that a bit. I'll just skip over that because we won't have time. I want to just point about work of breathing. And there are two sorts of work. There's airflow work and elastic work. And the picture on the right is out of Nunn, which says that the normal patient's normal respiratory rate that reduces workload to as little as possible is 15. And that's right. That's what it is. 7/10 was because we had extra resistance. And extra resistance demands a lower flow rate. If you get a very sick asthmatic patient, you are better off doing 3 700 ml breaths a minute versus 30 100 ml breaths a minute. Okay? You want long, slow, deep inspirations if you have airflow resistance. So if we want to look after someone normally, we should have a high rate because the tidal volumes will be less and the shear stress will be less. Okay, that's just the same picture. Now, the other thing is that when you collapse, you not only make the lungs smaller, you do several other bad things. Blood doesn't flow very well through collapsed lungs, so the pulmonary vascular resistance is up. Okay? And furthermore, lung compliance goes off. It gets much stiffer. You will need higher pressure. That'll make it much easier for you to ventilate the stomach by accident. And everyone here that's had trouble with mask ventilation, try to hold the mask with 2 hands, give the bag to someone else, squeeze hard, air in the stomach. Well, your day just got a lot worse, didn't it? Okay? It's all happened to us. So these machines can squeeze the bag for you with great precision and great accuracy instead of getting someone who's not an expert to squeeze the bag. Okay. So I'd like to talk about pressure support, and the basics of it are, for those who probably are not all that familiar with it, is that it detects the inspiratory effort by looking at a flow trigger. So when the machine realizes some air's gone in, the little red arrow appears on a flow curve, ideally, and the machine then increases airway pressure and gas flows into your lungs. And the increase is set by U, and that's the pressure support value. And the really clever bit is that the machine then watches the airflow curve until the point when the airflow is, say, a quarter of the peak airflow. And once that's fallen, so you breathe in, and your flow rate slows off. When the flow rate drops to a quarter, it says, oh, that's enough, you've had most of the air, I'll stop now, and it drops the pressure support out. So it's dynamically adjusting the duration of that increase to match what the person requires. Okay. So in other words, this system adapts to the patient's lung mechanics and breathing pattern. You don't need to change a lot of things. So that's it's like a zoom-in view. What settings do you need? Well, there are a couple of settings that make a difference. For most people that are conscious, as little as 5 is quite a lot on a Dräger machine. On a G, some of the other machines with bag and bottles, they behave slightly differently, so you need a little bit more. But 5 is quite a lot on one of these, and 8 is enough to ventilate normal lungs. I'll say it again. You do not need any more than 8 for a healthy, slim, sort of ordinary person to ventilate them very satisfactorily. And that's great to know if you can do that for laparoscopies and things. There's a thing called a flow trigger. A flow trigger is the sensitivity of the machine. If you set it too low, the machine might sort of oscillate or vibrate or self-trigger. But if your patient's gasping, going, well, that's a pretty high flow. What if it's a child and they're making small tidal volumes? So when they're very small, you might lower the flow trigger down. So a 10 kilogram child, you might use a flow trigger of 1 or 2, something like that. But you do need to modify it only really for children. Oops. And rise time is another parameter that you will see. If you've got gasping breath, like, you need to get that air in quickly. If you don't, the person will try to take that breath in and be flow-starved. So you want to bring that rise time down for people who are gasping, and for children who have a high respiratory rate, should be faster. But leave it at 0.3 for conscious people. And the last thing is, what does the machine do when the patient stops? Depends on the software on the GE machines. On the Dräger machines, that will always switch over very quickly to a self-triggering pressure support mode. And that time it takes depends on what you tell it the resting rate is. If you set the rate to 15, these machines will click over and start looking after the patient, in other words, ventilating the patient for you in 15 seconds, in around about 6 seconds. Now, I just want to show you, I don't know if I have the next slide. Right, this is what flow looks like with an I ratio of 1 to 2. Okay? I've exaggerated a bit, but just imagine that the patient exhales fairly completely in 2 seconds. So here we've got a complete inspiration. The airflow's gone in, you put the pressure up and it's gone in, and then it exhales. Now once it's exhaled and stopped, what good is that doing you? It's nothing. All that's happening is you've exhaled and you're collapsing, and you're not ventilating, okay? So if you ever see a flat flow curve, that's not what you want. You want to get rid of that. So you want something like that, okay? Because now you're using every bit of time to ventilate the patient. And that will give you the lowest CO2. And you can cut these short so they don't fully exhale and they don't fully inspire, but you should make them symmetrical in time. And then the alveoli will get bigger, and then they'll get smaller a bit, right? But there'll be air flowing all the time. That's what ventilation is. It's about airflow. Don't want to see that. And I'm going to talk quickly about compliance. That's a normal sort of compliance curve. You can see that if you look at the normal one with no PEEP down the bottom left there, 10 centimetres of pressure should get you over 800 mils of tidal volume. Now, how many people here reckon that they get that big a breath on their patients? Practically none of us. And why? Because almost all of our patients always have collapsed lung and we haven't reopened it. Okay? And so we get a curve like that bottom one there. So the whole purpose of recruitment is to try to fix that. And there's a thing called optimal mechanical PEEP, and that's where compliance is best. And I've got a process for doing that we can run through on the machine. In short, what it means is there's some point, which I've marked in red there, where for the same amount of, where you get the best tidal volume increase for the smallest amount of pressure change. And you can see that obviously in this person, about 10 of PEEP puts them in the middle of that most compliant point. But we don't know what that is for a patient, so how do we find out? Well, one way is to step the PEEP up with a constant pressure difference. Just ramp it up and look at the tidal volumes. And you will see something like this, where as you ramp up the PEEP, keeping the pressure the same in pressure control, that the tidal volume gets bigger and bigger and bigger up to a point, and then it gets smaller because you've overstretched them. Now, if you leave them up there for a while, they'll recruit a number of ways. This is a simple way of doing it. And then you can come back the other way. And when you come back the other way, you'll find something remarkable, that at some value, 8 or 6 or 4 or some value, the lung will be way stretchier than it was before. And that's because that lung is now being recruited and you're now able to ventilate it. And the shear stress and all those other things will be minimized. So this is a way to use tidal volume as a surrogate. Now, this type of machine is very modern. It will measure compliance for you. It will graph compliance for you trend-wise, and you don't have to do that palaver. But graphically, that's what you look like. You've changed this person from having a compliance that's very poor at low peaks to a much more compliant patient, and they'll be much easier to ventilate. You'll have much less shear stress. So these are a number of strategies to minimize airway pressure. They're particularly important in laparoscopies where you've got to get rid of CO2, and we can do them here. I'll show you some of them in a tick. So how do we stop the lung collapsing? Well, it's a bit multifactorial. 100% oxygen is not great. Apnea is really bad. If you want to do the test, get a patient and recruit them, okay, put them on your ventilator and put like a big amount of PEEP, I don't know, 6 or 8 of PEEP, something like that, or get the PEEP right, recruit them, and then just turn it off and disconnect them and count 60 seconds. Pretend you intubated them. And put them back in the same pressures in a pressure control mode, and the first thing you will see is that that next breath will be about 1/3 the size of what you had. And it'll get a bit better as you ventilate them. But their lungs collapse down to jelly in that 1 minute. It's really easy to demonstrate every patient you have. That's when it happens, when you intubate them. And it will also start happening if you're the sort of person who puts a mask on, pre-oxygenates, and then causes apnea. It starts right then. You've already got yourself behind the 8 ball. So one little thing here that I've learned that's really fascinating. Imagine you're ventilating somebody and there are bits of sputum in the airway. What happens to them? Which way do they go? Well, it turns out the drag is the 4th power of the flow velocity going past them, right? So if you go fast in and slow out, it's going to go in. That's what an I ratio of 1 to 2 does. You've got a higher flow rate in than you have out often. And so what you want to do is try to use, if you really want to get sputum out. But the most important thing we can do is something that I think you'll all feel very uncomfortable about, but I've now done for about 3 years, and that is, at the end of a case, I tend to sit people up, put the PEEP up a bit, and wait till they wake up. And electric tables are great because, you know, you can do that now without stuffing around. And then I would let the cuff down, put the sucker in and let the cuff down, and they cough, right? Some people cough. And I would think to myself, well, it's because I let the cuff down. It's not why they cough. They cough because above the trachea cuff, in the trachea, is all this saliva and stuff that you can't suck out. You can only suck out the mouth, okay? When you let the cuff down, it runs down, hits the carina, and that's what makes them cough. And you can put PEEP on and hope it'll blow it up. It doesn't. I've done the test, put coloured water in an endotracheal tube and let the cuff down. Doesn't matter how much PEEP, it goes down. Okay? And it sits above the collapsed lung, and if they're a little old lady who's got a fractured hip, she'll get pneumonia and she might die, and respiratory failure is what kills 30% of all the people that die after hip operations. So what you can do is keep the cuff up and pull it out with the cuff up. And you think, oh no, that'd be terrible, they'll cough and you'll wreck the larynx. But if the cuff pressure is about 15 or 20, which is plenty for ventilation with a high pressure, low volume cuff, you won't have a problem. And they don't cough. And if you put the sucker in the mouth and pull it up like that, it comes out real easy because the cords point upwards, that's the way they're designed, and it falls out and you realise why you have to tie them in. And when you pull it out, you'll hear a second bit of gunk will go out that sucker, and they would have breathed all that in. So I do that all the time. I do ANZCA and neurologists, and they don't cough. In fact, they cough less because they don't get gunk in the lungs to cough up. And I also don't like them putting lots of lube on the tube because they wake up with it. All right. So oxygenation, the key thing for us in theatre is low VQ ratio in parts of the lung and collapse. So you've got to recruit the lungs. You should optimise it. If you monitor compliance, you'll find it often tails off during the case and you re-recruit if you can. The ideal I ratio I've already mentioned. It's 1 to 1. But you should optimise the time so that they work. When you're doing laparoscopies, you want to go faster. Give inotropes if you need to give enough PEEP. You know, just don't not give the PEEP because you don't need it. All right, zip through that. And what I think we'll do is it is all for naught if you lie the patient flat, extubate them when they're still a bit paralysed or not really awake, either will do, and put lots of oxygen on them and have them zonked, okay? You might as well have just done nothing the whole time. They're going to leave your theatre, recollapse very quickly, and you'll get that phone call from recovery asking you to change the MET score to lower the saturation target, or should we run oxygen overnight, or something like that, okay? Now, I haven't sent, I send about 1 patient every 100 or 200 to recovery with an oxygen mask, and I've done that now for 3 years. Walk out of my theatre without an oxygen mask. You know, we do quality improvement conceptual models all, and I thought to myself, if I've done the right thing by someone's lungs, they ought to breathe well in air. That's what they did before they came to visit me. I'll see what I can do. And do all this stuff, it's unbelievable. They don't. My patients without an oxygen mask are doing better than the people with the oxygen masks. And is this dangerous? Well, I don't know. That's a tricky question. I don't think it is, because it's not hard to add a bit more oxygen. But if you look after them, you can do much better. So there's a bit of a summary here. What I'd like to do now is to, if it's okay, not have questions at this point, but swap over and we'll have a look at this machine. And I want to introduce you to a couple of test lungs that I've made. And could I just say, this video is going to be recorded and maybe put on Dräger's website or something like that. I have not had that done before, but I do this talk a lot. I would like a volunteer from the audience who wouldn't mind being famous. If no one will mind doing that, then I'll get one of the Dräger people to do it. But what I've got is a dummy lung over here. And if we could have the focus on that little lung right there, what I'll just quickly do is close an APL valve, and I'll just ventilate it here a bit. So the machine's all off. Okay, so I've got lungs going up and down, okay? Now we can make the picture just the lungs. So that's one thing we can do. The other thing is there's a handle on the lung. If I lift that lung, the bag will get smaller. And this lung has certain characteristics that resemble a normal lung. So what I want someone to do is to be the patient. And then we'll induce the patient and we'll see what happens to the waveforms on the machine and stuff like that. So is there anyone who wouldn't mind particularly just helping out a little bit to pull the handle? You happy to do that? Great, thank you very much. Very good. Just have a squeeze with that, and if you could tell the audience, we have a microphone somewhere. If you could tell the audience, does that feel like a normal sort of a lung, or is it a bit stiff?
A bit stiff.
A bit stiff, fantastic. Okay, now up on that screen there, I'm just going to take that big heavy magnet off. At the moment we're just establishing that it's not an unreasonable lung. I don't know if you can see, but I've got a broken off bit of Bic Biro in that plastic tube, and that reflects fairly normal airway resistance. I took that magnet off and I've run you out of gas, hang on. All right, I've made it a little bit softer. Can everyone now see that on that little lung? Let's zoom right in so we can see even further, more. Okay, so that's symmetrical, right? Air's going in equally. If you look at what it says therapy force for, but you can see some flow curves on that machine. And what I'll do now is we'll just come over to the machine, and what do we got to press here? Let's put the ventilator on just for fun, just to have a look and see what it would look like with a tidal volume of 700. Something we all know well, 700, don't worry about that. I'll give some gas in a tick. Respiratory rate of 10 and I ratio of 1 to 2. All right. Okay. Now we'll have a look at, thank you. Don't go away yet. Okay. So this is classical strict volume control. You look at that flow curve there. It's possible to see it's a fixed flow curve. I don't think there's a plateau on this one. And exhalation, big waste of time. Airway pressure going up. Okay, everyone happy with that? And we've got, what do we got for pressures here? We've got lots of numbers and they're all too small to read. I don't know if I can make it so that it looks better. Yeah, airway pressure, let's just choose that one. Oh, I've made it CO2, hang on. Let's just go to airway pressure. That's the plateau airway pressure. Oh, no, that'll be peak. How about we try just one other one? Sorry about this, because this is not my normal machine. So I'll just try to come down. Just want to make those numbers a bit bigger. Okay, that's better. So that's peak airway pressure, and it's pretty high. Okay? So is everyone happy that this is not such a bad lung? It's a bit stiff. It's quite a high airway pressure. So now then, what I'm going to do is say how I induce a patient with a mask. And there are a couple of tricks to it. If they have a beard, you're going to have a leak. You can get a defib pad and cut a hole, or a tegaderm and put it over the beard so that the mask seals reasonably well. And you need to plan ahead a bit if people have a beard. But in the main, I'll say to the patient, I'll say, sir, I'm just going now to show you a mask that I'm going to put on your face in a moment. And I show it to the patient, let them have a look, and I'll pop it on. I say, in a minute, I'll ask you to put your chin up, and then I'll pop that mask on, and we'll help you with your breathing, okay? And so what I'm going to do now is I'll put the machine sort of into standby, I'll put it into manual spontaneous, and I'll open the APL valve, and what I'd like you to do with your left hand, if possible, is just bring that up and down there, just breathe up and down. Try to get a feel for a normal respiratory rate. And you can see his whole body is swinging a bit because there's quite a lot of work in it. It's actually really hard to breathe. For us, it's unconscious, but there's quite a bit of work involved. And that's going up and down. And you can see we've got a tidal volume of 200, so I'll have to encourage you, Mr. Patient, to breathe just a little bit harder, okay? So I've shown you that mask, and now we'll get started, okay? So I'm going to say, all right, now I'm going to pop the mask on now. I've made you a little bit sleepy, but you've still got the same respiratory drive, so don't stop. And what I'm going to do is just confirm that you can breathe all right, and I'm going to press pressure support here. Now I preset this to a rate of 15, because that's normal. Pressure support of only 5, and I'll turn the PEEP off. Now, I'd like you to focus on the lungs at the top and the look on this gentleman's face when I turn it on. Okay, and the machine. So what's happening is, it is going to kick in, and there's some airway pressure come on now, and the tidal volumes have changed. And so I'll say, how does that feel? And the patient will say, that's okay, or something. If you get people who say, no, no, not the mask, I say, look, well, maybe it'll be different today because we've got a new machine, and it's quite clever, and it will help you with every breath you take. Okay. Now, is that as hard to do as it was? It's better than before. And are you feeling a little bit sleepy now? Right, I'm making you a bit sleepier now. All right, keep going with the same enthusiasm though, because you're anxious. I'm just going to add 5 of PEEP because I've established there's no leak, and so I'll do that. Now watch what happens with 5 of PEEP. The lung sort of fills up a bit, right? And the tidal volumes are still pretty good. Actually, they're bigger all of a sudden because the compliance is a little bit better with 5 of PEEP if you're supine. Now, you're getting sleepier now, so I'm going to ask you to put a bit less effort in. Keep breathing, but just a bit less enthusiasm, like a lot less. Keep going, but don't pull so hard. Now, I can see those tidal volumes dropping off, so what I'm going to do now is just dial up the pressure support a bit. In this case, I'll do it pretty quick. As a patient, you don't want massive tidal volumes, really. You don't need that much. At a rate of 15, you'll do fine, okay? And now I've given you some fentanyl at some point, and it's finally got the better of you. So just relax on the handle there and do nothing. Oh, what happened? Nothing. The machine kicked in about a very short time after our patient stopped because the algorithm says, wait only half a respiratory cycle. And my rate's 15. That's only 6 seconds. And look, the tidal volumes aren't bad. They're not perfect though. I wouldn't mind a bit more, so I'll just go up a little bit more. And so now what we've done is transition to a ventilator from spontaneous breathing in a manner that in a way is like magic. And I do it every day. And what are the advantages? Well, if you let someone get apneic, the tongue flops back. It acts like, thank you very much, sorry, thank you. The tongue flops back and it acts like a ball valve. And how do you get it up out of the way? You'll put a Goodell in, or you can apply pressure, but if you apply pressure, it'll push it down as well and block off. So sleep apnea patients have this type of machine at home in their kitchen, you know? And why don't we use these things to help us? You'll notice that I didn't touch the bag. I didn't need to. I didn't touch the APL valve. I didn't need to. If I had needed both hands to hold that mask because our patient was very large and was tricky, this little machine would do exactly what I told it. What's the odds I put air into this gentleman's stomach with such gentle induction? Hey? It's not much, is it? So when you do your laparoscopies, they ask you to put a gastric tube in, you can do that, but there's nothing coming out. So that's a demonstration of pressure support and how you can use it to induce a patient. Has everyone here used pressure support to wake a patient up, you know, like to wean a patient? Anyone here hasn't done that yet? No, all right, good. So I don't need to run through that, but it's obviously the reverse. What we'll tend to do is something like back off the ventilation somehow. But there's a trick to that. If you turn down, say, the amount of pressure you apply, the average pressure in the lungs is going to be less, and they're going to get smaller. What keeps your lung an adequate volume is mean airway pressure, okay? So let's say I do this to wake the patient up. Let's say I just turn the rate right down, and I turn the amount of pressure, wherever that is. I turn the pressure down, and I turn the rate down. Oh, okay. So the whole lung just says, ugh, you know, and goes floppy, okay? That's pretty useless most of the time. So what's going to happen? Collapse. Okay. So what can you do better? Well, what did I have that on? 12 or something? I can't figure out what I got to do here. Pressure support was 12, rate was 15. So I'll just put that back to where it was. And if I do that, you'll find the lungs get a bit better. But what you can do that's really clever is say, well, I've got two pressures here. I'll kind of put the PEEP up to 12, and I'll cut the pressure support back to 5. Okay, that's a better way to get the CO2 up. The mean airway pressure will be good, the lungs will stay open, you sit them up. 12 of people on just about anybody breathing spontaneously, when they start to put the gas, you know, in the right part of the lung down the bottom, which is what you do with your muscles, that'll be great. Your patient will recruit themselves sitting up in their bed, and you can pull it out because the tidal volumes are very small, but the ability to keep the lung open is very high. Okay? Good. So, so we've covered induction and a clever way of emerging people. Sit them up, pull the tube out with the sucker in the mouth with the cuff up or whatever. And these people will do really, really well. So another common problem would be trying to ventilate someone who's got a pneumoperitoneum. You know, you get people like that and you have trouble getting rid of CO2. If you don't have to worry about oxygen, CO2 is really easy. Thank you. What I'd be grateful for would be if you could just sort of lean down on that a bit. Make it so that it's like a pneumoperitoneum. I don't know how hard. Push it down. Not your whole body weight, but a bit, okay? And I'm going to put it back into classical volume control. And we'll just look, I think the pressures will get pretty high. So, yeah, this is what will happen. You'll have a high pressure alarm. Now, I might have to drop the PEEP a bit here just to put it back to a normal sort of frame. Okay. So the first thing you'll see is the air's now coming in and out really fast. It comes in and out faster because it's tighter. So the time constants are getting much shorter. So you are leaning on that, aren't you? You've got a good weight on it. What we could do, and achieving the same minute volume at a much lower pressure, let's just see what happens if I make the I ratio 1:1. So that's a pressure of 40. I'll only do that for now, and we'll just see what happens. I try to keep that constant. I know it's difficult, but just not more or less. I'll tell you what we'll do. Let's put the handle in the middle, up here. Yeah. Okay? Yeah. Just keep that constant. I'll go back. I'll wait till you get a feeling that you're happy with that, because otherwise we'll sort of... I'll go back to 1, 2, 1. Now, don't change anything. Don't take a breath. Okay? Thank you. What's that pressure? I don't know, 38 or something. All right, so we'll go now to an I ratio of 1:1. Now what's happened? Nothing much, 37. That wasn't much good, was it? So what I'm going to do is I will turn the tidal volume down and go faster, because we're wasting all that time in exhalation. Now in reality, you'll find often going to 1:1 will make a big difference. Okay. So that's dropped the pressures a bit because the tidal volumes are small. But what about we use volume autoflow mode, which is a volume guaranteed pressure control type mode. Let's just see how that goes. Now what's happening is the machine's applying a pressure trying to deliver the tidal volume, and that pressure is applied through the whole breathing cycle. But you can see, because this lung is exhaling so fast because of all of the compression, we can go much faster and do much better. So we could go as high as 17, put the tidal volume down to 400. When we get it so that the flow curve down the bottom here is all airflow, and I want to just get that 1-to-1, sorry. When there's no dead time, you'll get the lowest pressure that you could get for that particular lung. And the minute volume is still 6 litres. We can fiddle around a little bit, but you get the idea. We've taken 10 off the airway pressure. And in practice, you can take off more than that, and then you won't get the hits on the ventilator alarm. So this is a strategy that works very well. And you can see the lung is actually holding it open quite well now. It's not tending to collapse to nothing. It's going either side of the volume that you want it to have. Thank you very much. Okay, as soon as we release that air, up we come, and now at the end of the case, all of a sudden now, you can see those flow curves are different. If you look at that inspiratory flow curve, it's a bit truncated now, and the time constants have changed. So it's looking at the flow curves is very important. That if I was to make an obstruction here, let's put it into, I'll get the rate down a bit, and I'll show you what an obstructed airway looks like. Okay. That's should be an unobstructed airway. What I'm just going to do is to gradually kink off this here, and I'm watching the flow curve. What will happen is it will become flatter, more spread out. Now, I'm not sure what mode we're in, but you see that? If you're masking a patient and you see that, you've got an obstructed airway. And the treatment for that is PEEP or a Goodell or some other way to unobstruct it. Okay? And when you do, it'll look like that. Okay? So my eye doesn't look on the CO2 curve, I look on the flow curve, because the flow curve tells me how big every breath is and whether they're obstructed or not. I'd like to move on to some sort of more advanced things. Hypoxia in the operating room is usually due to unequal ventilation perfusion. I've got 2 models for that, but this is a very big magnet. It's really strong, and I've got lots of little cuts on my fingers because there's a partner to it underneath this bit of lung. If I put that there, it's going to want to drop it down. So I'll put the PEEP to 0. Okay. And what do we do? We use like a pressure mode of ventilation here, just for pressure of 8 or 10 or something. So what have I got? I got a rate of 12. It's in pressure control with an inspiratory pressure of 10 over 0. And what I'm hoping is that you can see that that little handlebar is not moving symmetrically. The air's going more into the side without the magnet. Okay? Yeah, all right. And this is what happens when you get collapse in areas around collapse. And that bit that's not being well ventilated, if it's got perfusion, is going to drag your saturations down. It will make your patient relatively hypoxic. As I said before, it doesn't take much oxygen to fix that, but there's another way of fixing that. So how about I try and do a recruitment maneuver on it, that one I described earlier, and we'll see what happens. We'll look at the lung and see what actually happens. In a non-homogeneous lung, your primary goal is to try to ventilate the stuff that's not doing very well. So, all right, what I would do is I'd put them in pressure control at a relatively low rate, Now you can see, by the way, look at that flow curve, there's wasted time on inspiration and expiration. These are not a setting I would use on this lung. I'd get rid of all the flat bits, and then you'll do best. But so here what I'm going to do is I'll just leave it at 10, that would do. Make sure the IA ratio is 1:1, roughly. Now, let's put 5 of PEEP on and see what happens to the tidal volume. So now I'm using the tidal volume as a surrogate for compliance. It's got lots of digits, it's a big number, it's easy to read. So this tidal volume is 163. We'll commit that to memory. I've added 5 of PEEP. And we look at the lung itself. It's sort of a bit better on the right side maybe, but the left side hasn't really opened very much. However, our tidal volume's gone up to 200 mils. So I'll put that up to 10 of PEEP. Now, I clicked it now, you'll see it kick in. Bing. Some magic point where you get to the compliance curve in good shape, all of a sudden my tidal volumes are now gone up to 350 or something, which is a lot better. Now, I didn't notice, but I've only actually set 8 of differential pressure, so that's why they're a bit low. But if we just think about the change in these volumes, that's quite impressive. But let's not stop there. Let's just show you what happens if you do a reasonable recruitment. Now, classical recruitment manoeuvres are, what, 30 centimetres of water for 30 seconds, you know, squeeze and hold. This is a little bit nicer for me, I think, because I'm actually still ventilating the patient, and I get an idea for what their response is like. Now, you can get the feeling now that there's air going into both lungs. A bit more on the right, maybe, still. And the right's looking perhaps a bit hyperinflated. Now, tidal volumes are 430. I go right up to 20. Okay. So now I hold this for 30 seconds, and you've got a recruitment manoeuvre. And you might want to give some aramine. It's a great test of hypovolemia. You'll see lots of swing on your outline. Now both sides look a bit inflated and they look pretty symmetrical. Okay? We've done our recruitment manoeuvre, let's say that's 30 seconds. What I tend to do now is come back and, depending if they're chubby, I might start at 16 or so, but let's just go straight back to, I'll do it in steps. We'll come back to 15. Now who can remember the numbers? Well, I can't very well, but it was like 160 at the beginning and then about 250 or something like that. So we'll just see what happens. And this is actually quite a good model because the magnet really only catches when it's small, and collapse tends to be one way. Once it's down, it stays down like a magnet. So we've got 370 at 15. I'll come down to 12. So for PEEP optimization, you just ease it down until you find the point where the tidal volume is best. And there'll be one big breath when you drop PEEP, but it really likes 12, that's good. 500 mils. I've got ventilation in both lungs. Bit more on the right. Come down to 10, and so on. And we'll just look and see what's best. And whatever's best, we can lock that in. And it's still pretty good on 10. So I like to have the lowest PEEP that's good, because that's the least hassle for the heart. You know, blood flows nice and easily through it. You get less alveolar dead space. It's kind of interesting that we're at 8 and it's still pretty good. I'll just go right down to 5. Now, this will be a bit of a test. Will 5 keep that bit open on the left? Well, maybe. Okay. For this patient, 5 is probably not going to be enough. And you can tell because the tidal volume's just collapsed in a heap. Okay. So this patient, you wouldn't just put 5 on, it wouldn't work. Okay, it wouldn't get you where you want to be. Everyone happy with that? And you'll notice that the flow curves have gone back to how they were and everything looks different. If I very quickly just put the PEEP up to a number that keeps it open very quickly, you'll see flow curves that look much better. All right. That's kind of what you want to see, a full sort of inspiration and air going in and giving it time to get in. And time's really important for resistive elements, so I've got a different model for that. So that's how you can recruit someone and optimize PEEP in one go. Okay? And this machine has a compliance trend, the mini trend thing you can put on the front screen, and you can then watch it fall away and tell you when you need to re-recruit them. Okay, everyone happy with that? I got another dummy lung here. This is special. I got 2 of those lung simulator things that they have, which don't have any resistance, but I put one of those bronchocath connectors. One runs directly to the lung, and the other one has a blocked off nasogastric tube in it, with which I can adjust the resistance of that connection to that lung. So what I'm going to do is put it up here, and just pause the box for a tick, and put this somehow here where it won't knock it off the table all the time. And I think I have to have an adapter for that because it's sort of back to front. Just got to hope I can connect these together. I don't think I can. I think one of these works. Oh. For some reason, the connector we've got today is different. Ah, there we go. All right. So now what I'd like to do is get the camera in there. This model has something that meant to emulate the pleural cavity around it, that tourniquet. So if we can make that, oh no, we'll leave it as it is, I suppose. Can you see pretty well on the screen at the top that there are 2 lungs? What have I got to do? So I'm just going to bag this lung. I've got a big leak somewhere. One of the catheter mounts is off. Okay. Why is that complaining about the oxygen? I'll just kill the machine off because it's run out of oxygen. Okay, now somewhere I've got to leave. This thing keeps popping off. Didn't used to. That's better. Okay. All right. So you can see when I'm doing this, I just got to adjust it so I'm bagging them. Where's all the air going? It's... Who put that alarm on? All right, so this is a funny looking lung from the ventilator's point of view. I don't have enough resistance in it. I'll just see if I can get a bit more resistance because that's not very realistic without resistance. And the problem is this connector is not a good one. That's why I had that there. All right, so now we've got some resistance. That looks a bit better, okay? Now, I'm just going to try, we've got the professional anaesthetist's hand will tell us just what they make of that one. Now, it's a small lung. We'll pretend it's a kid. Okay, is it leaking again? Has it come a droop? Feels like it's leaking. Shouldn't be leaking. Close that a lot. Anyway, we can ventilate that, but you're squeezing very hard. Squeeze a bit less hard. Okay, so what we're trying to do is to ventilate both lungs, and at the moment it's not working. The time constant of the one with the catheter in it is just too long. So what happens is it's gradually assuming the mean airway pressure. And I'm going to do this up a bit tighter and make it even harder. So we've got a fat person who is really hard to ventilate. What may I have the back? What I'm just going to do is I'm just going to drop this right open, completely open, get that lung empty. And I might just use the machine because that was hard to do and hard to control. So what I'll just do is put it into pressure control, start the ventilator, 2 of PEEP. What do we do? Get a decent tidal volume. I ratio of 1 to 1. No, we'll just leave it I ratio 1 to 2. This is what this is about. Okay, now have a look at the lung now. This is pretty classical pressure control ventilation. What you'll notice is that the lower lung element is inflating much faster than the other one and squashing the upper one. So this is what happens inside your lung if you've got a bit of spit in some airways. If you squeeze hard and fast, the air rushes in to the fast one, squashes it from the outside against the chest wall, and you just don't get good ventilation in that other lung unit. If I make it more extreme and do an I ratio that's even more inverse, so it's like 1 to 4, you'll see what happens here. The other one gets no ventilation, and you get hypoxemia. Now, will PEEP help this? Not much. I'll put 5 of PEEP on. And put 10 of PEEP on. Won't make much difference. Okay? And so these people go blue. And what's the treatment for it? Anyone think they can bag this patient and get good ventilation in both lung units easily? Not easily, but anyone want to have a try? You're welcome. Okay. So the trick is that slide that Nunn wrote about 60 years ago, which is that if you've got resistance, you need time. So let's just try that approach. So I'm going to put the I ratio back to 1 to 1, my favourite number. And we'll have a look at what that does. Now you see some gets in there, but it's a bit late. So how about we turn the respiratory rate down to a lower respiratory rate? I'll get that I ratio roughly 1 to 1. Without changing anything else, something is different happening. You can see that the upper lung is now getting a reasonable amount of ventilation. And in fact, when you turn the ventilator off, one of them exhales into the other rather than out your catheter mount. And if I was to make the respiratory rate even slower, and maybe just turn the pressures up a bit to deal with the fact the tidal volumes will be lower, let's see what we can do now. Okay, and that's much better. Okay, so we've gone from practically no ventilation to pretty reasonable ventilation. So these are some of the things that you can think about. There are times, like in a laparoscopy, when you want to go fast because the lung is going to exhale fast and equilibrate fast on inspiration. And there are times, asthmatics or people with obstruction, that you really want to go slow. And in a really extreme example, you want to go really slow. Like I would be much happier as an asthmatic with 4 breaths a minute of decent volume than lots of useless ones, okay? And you can put me on ECMO to get rid of the rest of my CO2, that's easy, but I don't want to have a problem with that. Okay, now I think we're out of time. Thank you for being so patient. Thank you very much to both my assistants, thank you. And I hope anyway to have stimulated some thoughts about how you can use these machines to start a case, to end a case, how you can make the lungs open and keep them open, and how you can deal with some tricky situations.